الجميل اللي احنا بنبقى حريصين ان احنا نبقى جزء منه. الجلسه الجايه اللي هتقولها البروفيسور ساميه نصر، اللي هي يعني دايركتور اوف سيستيك فايبروز ريسيرش سنتر في ميشيغان يونيفرسيتي. التايتل سيستيك فايبروزس complications and comorbidities.
السلام عليكم. ألف شكر على دعوتكم لمشاركتي في المؤتمر بتاعكم. أتمنى أن أنا كنت أكون موجودة in person، بس معلش إن شاء الله المرة الجاية. Today I'm going to be talking about cystic fibrosis, complications and comorbidities. The outline of the talk will be challenges in cystic fibrosis, pulmonary complications including pneumothorax, hemoptysis, hypercapnia, hypoxemia, and hypoxic respiratory failure, pulmonary hypertension, liver complication, GI complication, and CF-related diabetes. As you know, cystic fibrosis is a multi-system disease, so it affects the respiratory system, it affects the gastrointestinal system, it affects the pancreas and sweat glands, vas deferens, immune cells, and others as well. So today's focus is really on the complications of the cystic fibrosis. So the first thing I'm going to be talking about is pneumothorax. It happens spontaneously in an average annual incidence of 0.64% or 1 in 167 patient per year. The 2-year mortality is close to 50%. So we usually worry about it once it starts because that might be a bad indicator of survival. Lung transplant evaluation is recommended with the first one. So we don't wait to later. We just start with the first one to evaluate for lung transplant. Risk factors include severe lung disease, cysts in the lungs, blips, bullies within the lung parenchyma. This is an example of pneumothorax. You can see in the left is a chest X-ray, and it doesn't really show it that much, but when you do the CT scan, it's clearly there. So keep in mind that chest X-ray might not be a clear diagnostic tool for you. So if you think there is something going on and the chest X-ray is not helping, then go ahead with the CT. The other thing about this chest X-ray is that it shows severe disease. I usually can score the chest X-ray, so when I come in, I can show you how to do that. But it seemed like this patient has severe lung disease, so the pneumothorax would not show as clearly in this lung. So it's not surprising that it's showing more in the CT. The primary symptoms are acute onset chest pain, worsening dyspnea, tachypnea, and hypoxia. And I have a patient that came in. He didn't really complain of a lot of chest pain. He just at the end of the visit said, you know, I have some pain in my chest, but his pain tolerance was quite high. And his lung function was worse, and he was definitely worse. So we did a chest X-ray, and actually it showed pneumothorax. The diagnosis in all patients with pulmonary exacerbation, as the symptoms might overlap. So you might admit a patient or you might treat a patient as pulmonary exacerbation, but then they're not responding as well or they're still having symptoms. So keep in mind pneumothorax. And then again, the chest X-ray demonstrates free air within the thorax, and small pneumothoraces may require chest CT. To treat pneumothorax, outpatient observation of small ones. If you have a small pneumothorax, and that's like less than 3 centimeters in the chest X-ray, then, and if the patient is clinically stable, then we usually start with antibiotics orally and send them home to be watched, and they call us every day to make sure that we are on top of it and making sure that things are going well. We usually bring them back and repeat the X-ray within a week. In this situation, you can continue with airway clearance, hypertonic saline and pulmozyme. But if you have a large ones, and then that's more than 3 centimeters, then you should be monitored in the hospital. And usually if there is pneumothorax in that size, I admit them. We stop the airway clearance, we stop hypertonic and pulmozyme, because that might increase the size of the pneumothorax. Till we have a good handle on the pneumothorax, then we can restart it. Evacuation of the pleural space via thoracostomy tube for patients are important, especially if they are unstable or the pneumothorax is large. We treat with antibiotics, IV antibiotics, if they are admitted to the hospital, as it's an exacerbation. And cases of persistent air leak may require pleurodesis. And our surgeons are very experienced in doing that. And that does not disqualify them from lung transplant in the US. And then the recurrence rates are high, with estimated up to 50 to 90% of the cases. So we usually keep a very close eye on these patients. Next, we're gonna talk about pneumothorax, hemoptysis. And it's classified as scant, could be classified as a scant, meaning blood-streaked sputum, or mild, less than 5 ml, or massive, more than 240 ml in 1 day, or 2 days of larger than 100 ml. The results of chronic, it is a result of chronic local and systemic inflammation leading to localized destruction of the airways epithelium, leading to bronchiectasis and increased growth factor, promoting the development of bronchial arterial hypertrophy, leading to enlarged and tortuous and dilated vessels, and result in rupture into the airway. And as you noticed, it's the bronchial arteries that usually have the hemoptysis coming from. The incidence and prevalence are as high as 21 to 31 over 6 months, or 9% over a year. So it depends on the statistics you're looking at. Massive hemoptysis is a life-threatening emergency, and the median age for this complication is about 23. So we don't see it too much in pediatrics, but it can if the lung disease is severe. So if the lung disease is severe, then you see it. I used to see it a lot more previously, and recently with the advances in treating CF in the US, I don't see it as much, but we do see it from time to time. To treat hemoptysis, it is similar to the usual pulmonary exacerbation. Again, both hemoptysis and pneumothorax we treat as pulmonary exacerbation, because that is the result of damage to the lung that caused both of them. In mild hemoptysis, we do continue airway clearance, even though I tend not to. I continue it if it's a scant, but if it's mild, I probably would stop it. In massive hemoptysis, a temporary hold on the airway clearance, but also pulmozyme and hypertonic, because it could be irritating to the airways. Assessment to identify and correct any underlying coagulopathy is important, and bronchial artery embolization for massive hemoptysis or severe instability is recommended. And we usually, actually, our intervention radiologist ask us to do bronchoscopy at the time to localize where the bleeding is coming from. A lot of the time, the patients can tell you as well. I have patients that tell me, I feel it coming from my right side or from my left side. But we do bronchoscopies for them to localize where the bleeding from, so they can target that with their intervention. It is poor prognosis, and its attributable risk for mortality is between 5.8% to 16%. And we usually also do the transplant evaluation at that time. Next is the hypercapnic and hypoxic respiratory failure. The chest pathogenesis with mucus stasis, chronic airway infection, and inflammation all leads to airway remodeling with progressive bronchiectasis and obstructive lung disease. And that happened in severe CF lung. As a result, ventilation perfusion mismatch happen, and chronic respiratory failure marked by hypercapnia, hypoxia, and or both can happen. The symptoms are usually morning headache, fatigue, and poor sleep quality. Diagnosis mainly by blood gases, and treatment is we can do nocturnal non-invasive positive pressure ventilation, which is the NIPPV, which I know is in Egypt, and or supplemental oxygen as needed. It depends on the situation, of course. Excuse me. Also, they might have sleep disturbance. There is a new article that came out that we actually did in our center, where we screened CF patients, especially with severe lung disease, and a significant number of them had severe obstructive apnea. And you need to keep track of that as well. And also, I know that the sleep studies can be done in Egypt. So usually in the situation like this, you might want to do also a sleep study. Pulmonary hypertension, I used to see a lot of it early on when patients were more severe, but right now I don't see it as much. So but it happens with severe lung disease. Chronic hypoxemia induces the development of pulmonary hypertension, characterized histologically by pulmonary vasculature remodeling via subintimal fibrosis and muscularization of pulmonary arteriole. The incidence is unclear, but the rate can be as high as 57% in advanced CF patients. To diagnose it, you really need to do a transthoracic echocardiogram. The gold standard is the right heart catheterization because it is usually right-sided heart failure. We used to do a lot of them, like I mentioned, but we haven't recently because I don't have that many with advanced lung disease in pediatrics. Treatment is limited with exceptions of supplemental oxygen in chronic hypoxic patients. Acute respiratory failure may require advanced life support, including mechanical ventilation or extracorporeal membrane oxygenation. And I've seen that in patients with mild CF, that all of a sudden they can get pneumonia and then go into acute respiratory failure. And we do, in this situation, provide them with mechanical ventilation. When you do mechanical ventilation for CF patients, that's usually a bad sign, and that a lot of the time they don't recover from that if it's a chronic situation or severe lung disease. But in acute respiratory failure, you can use it. Now we're moving on to the GI system. So CF liver disease. So keep in mind that non-pulmonary causes of mortality in CF is 2.5% to 5%. The CF liver disease classically has been considered as a channelopathy. CFTR expressed in the apical membrane of the cholangiocytes and is a major determinant of bile secretion. CF lung liver disease represents a severe complication in the management of CF patients. If severe, it is life-threatening and can lead to liver transplant. And we have few patients, teenagers actually, that needed liver transplant. The symptoms could be asymptomatic. We do liver enzymes yearly. So once we see it creeping up, then we have to think about liver disease. Biliary cirrhosis with or without portal hypertension can happen. And again, I've seen several patients having that. Usually we have our gastrointestinal colleagues following with us as well. Portal hypertension in the absence of cirrhosis can happen. And also the other way around, cirrhosis without portal hypertension can happen. And then the presence of micro gallbladder and steatosis are actually common, and I see that in pediatrics often. It can correlate with more severe mutations, class 1 or 2 or 3, pancreatic insufficiency, male sex, and meconium ileus at birth. So meconium ileum at birth. So when these risk factors are present with increasing liver enzymes, then keep thinking about liver disease. The treatment currently is treated routinely with ursodeoxycholic acid, especially if there is a gallbladder sludge that we usually diagnose with abdominal ultrasound or CT scan. For liver cirrhosis, supportive treatment is indicated, and that include beta blockers or transjugular intrahepatic portosystemic shunts to treat portal hypertension. Liver transplant for severe liver dysfunction is recommended. And actually, I know that there was a case that Dr. Iman mentioned that had liver transplant in Egypt. So CFTR in the digestive system, it's mainly the CFTR, is like, you know that the ionic content is important. Fluid, the increased prandial pancreatic duct secretion, and then the pH adjustment is important as well. It promotes bicarbonate ion secretion, and there is a highest level of CFTR expression in the duodenum to neutralize the stomach acid. The CFTR in the gut is the highest in the duodenum, as I mentioned, and that is, and then it decreases as you go into the GI tract, so it's the lowest in the ileum. The CFTR highly expressed in the duodenum. It's localized the localization of the CFTR reflects need for bicarbonate secretion to neutralize the acidity during the gastric emptying. And the pH regulation in the duodenum is crucial for optimal activities of the pancreatic digestive enzymes. The consequence of CFTR dysfunction is obstruction, and I think I'm getting close to the end of the talk here. So there definitely can be obstruction, abdominal discomfort, meconium ileus in the neonate, and distal intestinal obstruction syndrome as the patient gets older. Pancreatitis can happen in CF. It happens usually in CF pancreatic sufficient patient, and when that happens, they become more insufficient. And there are specific mutations that can suggest or pancreatitis or correlating with pancreatitis. There is the microbial dysbiosis is known in CF. That is usually you have to keep track of that as well. So GI are very important in this situation. Small intestinal bacterial overgrowth can happen. And I see that often actually, and I send them to GI to manage as well. The last few slides is about CF-related diabetes. Keep in mind that diabetes in CF is not type 1 or type 2. So it's kind of in between. So the most common age of onset is 18 to 21. However, we start testing at 10 or younger if indicated. Usually the patients are thin, insulin secretion is low, insulin sensitivity is low as well. So similar to type 1. Autoimmune etiology is not known in CF-related diabetes. And as you can see, the rest of them. So right now, the last one, the microvascular complication, we used to say no, but as the patient is living longer, they are having it as well. So the factors unique to CF, usually patients are under nutrition is a risk factor, chronic inflammation and intermittent acute infection, glucagon deficiency, altered intestinal nutrient absorption and transient time, and hepatic dysfunction, and also increased energy expenditure, all are risk factor. And if they are thin and low lipid levels, normal blood pressure are usually there. So the symptoms, I don't see as much polyuria and polydipsia, but it can happen. I see more of a failure to gain or maintain weight despite nutritional intervention, failure to grow or delayed progression of puberty. And naturally, there is delayed progression of puberty in CF. And then chronic decline in lung function that I cannot explain by any other reason. And a lot of the time when I admit them for CF exacerbation, and if they are not responding well to my treatment, then I have to think of diabetes. We usually check their blood level, their glucose level when they come in, and we check it periodically during the admission, and we've diagnosed several CF-related diabetes during the exacerbation or interpreted as exacerbation, but it wasn't. So at 10 years of age, we usually start the oral glucose tolerance test, which is the pre-brandial and 2 hours. We don't do the 1 hour. It's not needed actually for CF. So we do it at 10 years and older. We do it for patients taking high dose steroids, frequent CF exacerbation, pregnant patients, or if there is a strong family history and the parents are worried about it, I usually do it. Hemoglobin A1C is insensitive in the diagnosis of CF-RD. However, we do it yearly in our center as a predictor of diabetes. I'm going to skip this slide. So in summary, diabetes is common in CF. Routine screening is very important, especially 10 years and older, like I mentioned. And then CF-RD is a distinct form of diabetes requiring its own management approach. They do not treat it with oral diabetic agents. We usually have to treat it with insulin because the absorption is not that good. So we do treat it mainly with insulin. This approach should be flexible, mindful of nutritional issues and adjustment for acute illness. And we usually let our dietitian follow these patients. We do not have the endocrine dietitian following, because the way to treat diabetes in general doesn't really apply to CF. We don't restrict their calories. We don't restrict their carbohydrate intake. We adjust, and also some of them, especially with diabetes, have gastrostomy tube, feeding at night. So we have to adjust the insulin dosing according to what their needs are for weight gain. So this is the last slide, and it shows the survival for CF patients, and that you can see that in the last few years, their survival improved significantly. And right now, the median survival actually is 50 years this year from the CF Foundation, and we're hoping to continue to get better. We are seeing more and more adult CF patients in good shape generally. So with that, I'm hoping that curve will be applying to Egypt as well. And thank you very much again for inviting me, and hope you guys have a great meeting and a great day, and we'll see you soon, inshallah. Assalamu alaikum.
وعليكم السلام ورحمة الله. Thank you, Dr. Samia, for the very interesting topic and lecture. But I have a question for you, dear Dr. Samia, please. We know that respiratory support, including hypertonic saline. مش online؟ online؟ طب تمام. كنت بقى هي المحاضره كانت على الكومبليكيشنز. احنا عارفين طبعا ان احنا الريسبيراتوري سبورت، الهايبرتونيك سلاين، البالموزايم، الشيست فيزيوثيرابي، انهيلد انتي بايوتكس، كل ده بيحسن البالمونري فانكشن، ديلي ان يدخل في البرونكيكتسز والريسبيراتوري فيلير. كمان النيوتريشنال سبورت مهم، والبانكرياتيك انزيمز ريبليسمنت تحسن النيوتريشن، تحسن الجروث. بالنسبه للهيباتيك كومبليكيشنز، ايه الحاجه اللي ممكن نعملها عشان نقلل الهيباتيك كومبليكيشنز، الكوليستيزيس، او ان هو الطفل يدخل في دايابيتس؟ هل the only way ان احنا نستخدم السيفتر موديوليتورز، ولا في حاجه ثانيه ممكن تبقى سبورت؟
طبعا انا هجاوب حدود المعلومات اللي عندي. طبعا هو هناك في يو اس اي ما عادش المشكله دي عندهم كبيره قوي، لان عندهم سيفتر موديوليشن موجوده دلوقتي بيستخدموا الترايكافتا. فقط بالنسبه للمشاكل عندهم ميديكال سكرين، وبالتالي العيان بتشخص فروم ذا فيرست داي، وبيتعمل له جين فروم ذا فيرست داي، وبالتالي بتبقى المساله بالنسبه لهم سهله. احنا هنا بالنسبه لنا الفولو اب بتاع الهيباتيك افكشن بيتم بالالترا ساوند وبمتابعه الليفر فانكشن continuously every 6 months for our patients، وبنستخدم المانجمنت المعتاد، يعني الحاجات العاديه اللي بيستخدموها البايل سولز والحاجات اللي زي كده دي بس اللي بنستخدمها، لكن ما عندناش حاجه محدده. اي ثينك هناك عندهم عشان هم they are aborting الديزيز pathogens from the beginning، الدنيا بتبقى افضل كتير.
الاونلي بروتكشن فعلا السيفتر موديوليتورز
والمتابعه، لان احنا عندنا ان احنا حتى ايفن عملنا ريسيرش حوالين الموضوع ده. البيشنت بيبتدي فيري ايرلي بهيباتيك انفولفمنت في الفيرست يير اوف لايف، اكشولي ده بور بروجنوزز والسرفايفل ريت بتاعهم بيبقى قليل قوي. لكن على المدى البعيد احنا عاملين بروتوكول عندنا في عياده السي اف ان البيشنت بيتابع افري 6 مانثس بالالترا ساوند وبالليفر فانكشن والالكالاين فوسفاتيز بشكل خاص.
تمام دكتور، شكرا لحضرتك.